conversation. And my thanks to Quartet for convening this very important symposium. The topic of our session is addressing transportation emissions to improve health. Of course, there is much concern about emissions that are emitted, particularly in the transportation sector. And because of the economic growth and population growth that we are experiencing in this country and around the world, the number of vehicles that are being used each on a daily basis and miles driven by individuals are having the impact of increasing emissions or causing emissions to be at levels that exceed public health thresholds. And while we have seen significant progress in the quantity of emissions emitted by different types of vehicles over the past decades, we still have significant improvements and progress that need to be made. In this afternoon, we are blessed with a very gifted group of researchers who have, through their extensive work, are sharing with us the results of their research that has the potential to inform public policy to make sure that we are reducing these emissions as we proceed so that public health is assured for all of our citizens. We have three, as noted, we have three very talented presenters. So let me give brief bios of each one. Let me back up and say my name is John Hall. Earlier in my life, I served as chairman of the Texas Commission on Environmental Quality and have worked on air quality and public health issues in Texas for the past 35 years. Now, our panelists. Our first presenter will be Dr. Juan Aguirre, who is a postdoctoral research fellow at Stanford University. And he has joined the Sean N. Parker Center for Allergy and Asthma Research. His research focuses on understanding the impact of air pollution on cardiorespiratory health in at-risk populations. Juan obtained his PhD in interdisciplinary health sciences from the University of Texas at El Paso and his MD from the Autonomous University of Ciudad Juarez, Mexico. He has investigated the negative effects of traffic-related air pollution on physical activity in children with asthma, as well as associations of traffic and transportation-related variables and cardiorespiratory biomarkers in low-income populations from a border community. His topic is entitled Short-Term Association of Traffic-Related Air Pollutants on Cardiorespiratory Factors from Low-Income Populations in El Paso. Our second presenter will be Perry Hystad, who is an associate professor in the College of Public Health and Human Sciences at Oregon State University. He is the principal investigator of the Spatial Health Lab there, and his research focuses on environmental exposure assessment and epidemiological methods to guide prevention and regulatory measures. His topic that he will be speaking to is entitled The Transit Accountability Study, Preliminary Results and Methods to Assess Impacts of Local Congestion Programs on Pregnant Women in Texas. And our third presenter is Jill Liu. She received her PhD degree in environmental engineering from the University of California, Riverside. She's currently an assistant research engineer at that college at the Center for Environmental Research and Technology. Jill's research focuses on ITS strategies to mitigate human exposure to traffic-related air pollutants. Her topic for this afternoon presentation is reducing community exposure to diesel emissions through health-conscious truck routing. Each presenter will take about 15 minutes. Afterwards, we will go into a question and answer period for approximately 20 to 25 minutes, and we will close with each presenter providing closing remarks. Again, thank you all for attending. And Juan, we are eager to hear from you, so please proceed.
Thank you so much, John, for your wonderful introduction. Can everybody hear me okay?
Yes.
Excellent. Yes. Well, I'm happy to be here, and thank you all for joining. I would like to offer this opportunity to give a shout out to all our amazing collaborators and organizing committee from the CAR-T. Thrilled to present some of the research work that was part of my doctoral studies. And speaking about the effects of traffic-related pollutants, it's important to know that we consider this a complex problem. And in order to find solutions, collaboration is essential. So we had very different collaborators from opposite sides of the spectrum, from the health sciences to public health to going through interdisciplinary studies and engineering departments, the statisticians, which I think it's essential in order to find what are the main causes of all these problems that are affecting our health. And I mean, air pollution is no different. We know that about 43.5 million are exposed to traffic pollution in the US, and this is measured considering those that are living within one block of a heavy traffic road. And sadly, it is more likely to affect those living in underserved communities. There's abundant evidence for the health effects that air pollution has on the human body, and recently, even increases in mortality have been shown due to the cardiorespiratory complications of living close to air polluted areas. I mean, we're no strangers to the respiratory effects, where traffic-related air pollutants are one of the major preventable causes of respiratory disease. And this exposure of inhalation to air pollutants is increasing the possibilities of airway inflammation. It decreases exercise performance, and of course also in long term it's going to have a decrease in lung function. But recently we've been more aware about what are the systemic complications of exposure to traffic-related air pollutants and air pollution in general. I mean, the biological pathways linked traffic pollutants have shown that it affects cardiovascular disease through intermediate pathways and subsequent biological responses. I mean, we've seen that there's pulmonary oxidative stress and inflammation, which is going to lead to activation of the lung function. And I think I lost my slides here due to a misclick. Let's see if we can recover them. Give me 1 second, please. Perfect. So this activation of the autonomic nervous system due to the responses of inflammatory triggers is also going to lead to an imbalance that might affect our heart palpitations, leading to arrhythmias. And also smaller fine particles are going to penetrate our lung system and go directly into the bloodstream, where we're going to see the effects of systemic oxidation, stress, and inflammation, which very likely is going to lead to cardiovascular disease. And it's important to consider that short-term exposure assessments have been done in the past. However, the time periods of exposure for some of the biomarkers are not clearly defined, and we've seen very different studies considering very different type points and cutoff values. However, it's important to notice that some of these studies have concluded that air pollutant concentrations over short periods, even of 1 or several days, are going to lead to increased cardiovascular disease morbidity and mortality, with effects even in blood pressure values, HDL and LDL cholesterol, glucose, and glycated hemoglobin being affected by even considering 1-day averages up to 2 to 6 day averages of particulate matter. Other studies also have focused just on HDL cholesterol, sometimes referenced as the good cholesterol, finding that even a high level of PM2.5 from the previous 5 days of measurements have been related to that. Even often cited epidemiological study known as the MESA study has considered these daily exposures not only on the short term, but also consider medium-term exposures going up to 30 days and 60 days of values for particulate matter, nitric oxide, and ozone. So through this research, we have the opportunity to partner with communities, low-income residents, NGOs, and very different partners from the city of El Paso, which is featured here in the map. Where in a study, we visited more than 5,000 low-income residents from the last 6 years, so basically 2014 and 2020. For this presentation, we're going to consider the first year of data collection in which 662 residents from low-income communities within the Housing Authority for the city of El Paso were interviewed and allow us to collect blood measurements and respiratory measurements on these visits. And here in the map, we're showing the approximate location for each participant, and you can see that our representative sample does capture several communities and areas from the different points in El Paso, Texas. Most of our participants were women, and this community is largely Hispanic, especially since it's located in the U.S.-Mexico border. We can see below in the map that Ciudad Juarez is featured as well. Sadly, we couldn't do binational collaboration, but we're looking forward for that in the near future. So for respiratory measurements, we consider factors for lung inflammation measured as the exhaled nitric oxide level. And for lung function, we did a spirometry test in which we measure the forced vital capacity, the forced expiratory volume within the first second, and peak expiratory flow, which are common measurements done for spirometry assessments to determine the lung function of each participant. And also, we were able to conduct some cardiovascular measurements. In this regard, we'd often use what is known as the metabolic syndrome, in which a person having 3 out of 5 risk factors is considered to have a metabolic syndrome that will be a risk factor itself for cardiovascular disease, obesity, and diabetes. So you can notice that the 5 components include a large waistline, a low level of the good cholesterol, HDL, a high level of triglycerides, a high level of fasting glucose, and high blood pressure. If a participant had 3 out of these 5 factors, we will classify that person with having metabolic syndrome, and the prevalence in the US, it's about 23%. However, in our sample population, we would see that it's much higher. And we paired up this information with air pollution data available through the EPA central monitoring stations, which capture the amounts of ozone, PM2.5, PM10, measures for particulate matter, nitric dioxide as well. And we did an approximation based on the residential address for these participants and the average values of air pollution concentrations, 24 hours, 48, 72, and 96 hours before the health data assessment. And we can see, first of all, considering just the central air monitoring results, we would notice that the variability between the levels of air pollutants would be somewhat stable. We didn't notice any major variation when considering some of the range values. And we would notice that as time goes on, the ranges just starts to decrease, which would indicate a more representative air pollution value related to the neighborhood conditions, as we would see also from the associations. So when just considering the respiratory outcomes, there were several factors for the exhaled nitric oxide. We saw some ranges of very high levels of airway inflammation. However, the majority of them were still within a normal range, and with the median around 20. parts per billion. And then for the spirometry measurements, we could assess the forced expiratory volume, the forced vital capacity, and the peak exploratory flow, which would see they would be associated later on with air pollutants. So when we start to pair up this information with the amounts of air pollutant concentrations, considering each of the cut points for the different associations, it was expected that we would see that, for example, PM 2.5 would be related to a forced expiratory volume, to a decrease in forced expiratory volume, especially considering the air pollution from the last 24 hours and 48 hours. This would also affect the amount of the peak exploratory flow, which means the amount of air a participant is able to breathe out after 6 seconds when determining the lung function. And we would see that as air pollution increases, we would see a decrease in this value, with also associations between the ratio of the amount of air you're able to breathe out in the first second and the forced vital capacity, which tells us a little bit about the nature of these values. So for example, when we see that this ratio is affected, we're talking more about restrictive diseases in regards to your respiratory flow. As far as long-term, we did consider that, and we did a separate study considering the 5,000 participants that were shown part of the epidemiological study, and that is part of another presentation. But definitely, I'm looking forward to share those findings later on also as a separate topic. And it's also being prepared for publication on the transportation research record. So thank you for asking that, Hanan. And moving on with the cardiovascular outcomes, I think this is where some of our data became a little bit more interesting, because I also forgot to mention, related to Hanan's question, is that the respiratory markers were only collected for the first year of the data due to budget cuts. And it's because funding issues with the agency. And it is a shame because we couldn't continue to do respiratory assessments. However, we could continue focusing on the cardiovascular outcomes. And of course, Hanan, we will look into the short-term peaks as well. So when looking at the cardiovascular outcomes, we were expecting some variation based on the previous reported literature, particularly in maybe blood pressure and glucose. However, we noticed that the more significant trends were related to more chronic outcomes, such as obesity. And we can notice from the sample in our participants, BMI was particularly high in this participant, with even some of the medians going into high levels of obesity. High waist as well was one of the major problems we saw in this community. And also the levels of metabolic risk factors were above the medians for blood pressure, triglycerides, and also for glucose. It's not switching, there we go. So now when we started to look at the cardiovascular associations, we included BMI, even though it's not a metabolic risk factor. However, due to its relationship with waist circumference and obesity, we wanted to see if some associations were present. But we were pleasantly and unpleasantly at the same time surprised to see that as the PM 2.5 values and other markers as well continue to increase, we would saw increases on the waist circumference, even when considering short term. This is interesting because it's not that the air pollution exposure in the short term is necessarily causing obesity. However, given the variability ranges we saw in these participants, we can infer that some of these associations can be attributed to the neighborhood and environmental conditions of each participant, which later inspire also some of our land use regression models. So some of the conclusions were that we needed to be looking into obesity as a predictor and something that will be related to the amount of air pollution exposure. And also glucose was related with 24 hours and 48 hours exposure to increases in particulate matter. Furthermore, since we have cutoff values for these markers, I mean, we can consider those that were high or low waist circumference, high or low HDL and glucose. So we did logistic regression to further see the associations, and they were preserved, particularly when considering the circumference values, the amount of HDL. We saw associations as well with traffic-related air pollutants. And with high glucose, it was very similar to the linear regressions, in which we saw the relationship still preserved among those that have a high glucose compared to those that didn't. And now integrating the metabolic syndrome, which I might remind the audience, is having 3 out of the 5 risk factors, would also lead to some interesting associations, but more in the long term for PM2.5, nitric dioxide, and opposite relations with ozone. These opposite relationships with ozone are likely explained because of the different trends we see with the amounts of ozone and nitric dioxide, which was probably carrying out the levels we would see in our models. So as I mentioned, indicators of obstructive respiratory diseases like asthma and chronic obstructive pulmonary disease were related to air pollutants. Once again, I want to remind the audience that these are associations, and given the nature of the study, we cannot infer causation. However, it's interesting to note how it was somewhat expected that expiratory flows and peak expiratory flows for spirometry would be related to air pollutants. However, we did not find any associations with cell nitric oxide, which was something we weren't expecting this population, since often we see associations between both airway inflammation and decreasing lung function. And as I mentioned, the positive correlations between air pollutants and obesity outcomes on the short term might be more likely an explanation of chronic exposure. In this regard, we infer that environmental and neighborhood conditions are playing a role, in which just the amount of air pollution is being related to the locations where each participants are living. And that would explain some of the short-term associations, which to kind of crisscross with another study that we did, we actually found associations were preserved on chronic exposure and relationships with traffic. However, we also found that fasting glucose and particulate matter were associated on the shorter term when considering the 24-hour and 48-hour exposure, in which some of the mechanisms could be attributed to oxidative stress and inflammation due to the air pollution exposure. And this is just to illustrate how we can see that considering the average values, the range of the particular matter and in regards to the other air pollutants tends to shift. And as we further consider the air pollution exposure, we are capturing some of the neighborhood and environmental conditions for these participants. And of course, we need to consider other limitations as well. I mean, it's important to know that these are measurements from central air monitoring stations, which are being interpolated to the residential exposure for each participant. And we weren't able to do on-site measurements for these participants in the communities. And also, when considering ambient air pollution, we're not considering the indoor environmental variations. So we do know from previous literature that there's a correlation between the outdoor and the indoor air pollution. However, the variations are not accounted for. So that's also important to consider for further research. And in summary, we'd like to remind the audience, I mean, we saw respiratory outcomes associated to short-term air pollution exposure, which has been shown before in previous study. However, this study might be the first to consider short-term exposure and air pollutant relationships with obesity, which would be further studied to consider what are the chronic effects and what will be the explanations due to this short-term association. And also, as emerging data is suggesting, effects of air pollution are being associated with fasting glucose, which also could lead to diabetes, and further studies to consider also measurements for diabetes diagnosis and even glycated hemoglobin. And with that, I would like to acknowledge the Center for Advancing Research in Transportation Emissions, Energy and Health, which partly funded this research, and also our collaborations with the City of El Paso Department of Public Health, the U.S. Department of Transportation, which was also involved thanks to CAR-T, and to remind everybody that the contents of this presentation are responsibility of us and author and do not represent the use of the US DOT. And I would like to thank you, everybody, for your time, and remind everybody that interdisciplinary health involves devotion to lifelong learning and collaboration, and we need to work together. We want to solve complex problems like the ones that we're affecting now with the current climate crisis. We need to set standards of care and disease prevention for anyone. So thank you so much for your attention. And I would like to open the floor for questions, or are we having them after the talks? I'll leave it to our moderators. Thank you.
Thank you, Juan. So next we will have Perry. And if Perry, you could just pull up your slides. We will save questions to the end. Thank you.
Great. Okay, can everyone hear me okay? Start my little timer here. Okay, so my name is Perry Hystad. I'm at Oregon State University, and I'm going to be presenting on the Transit Accountability Study, where we're assessing the impacts of vehicle emission regulations and local congestion policies on term birth outcomes in Texas. So this is a large study. I'm just going to be presenting one component today. That's looking specifically at local congestion. There's a large team of people that led to this research, so this is definitely not my research that I conducted. This is a team effort. And please feel free to post questions as I go along. Sometimes you just feel like you're presenting to yourself on the computer. So it's nice to see questions coming in and people are actually listening out there. Today we've heard a lot about traffic-related air pollution. I'm going to refer to TRAP as all of the air pollution emissions that come from vehicles. So this is vehicles, trucks. Primarily, we've been concerned about tailpipe emissions, but as we see those are being reduced quite a bit over the last decade, we're also starting to pay more attention to other sources of air pollution. So this can be tire and brake wear, this can be road resuspension, or just fugitive emissions from the engine. So when I refer to TRAP, that's all air pollution emissions coming from vehicles. So we are specifically focused on adverse birth outcomes. So this includes such outcomes as preterm birth, low term birth weight, small for gestational age. Traffic-related air pollution has been robustly linked to these type of outcomes. This figure here shows a meta-analysis looking at NO2 in term birth weight. NO2 is used as a surrogate measure for, again, all traffic-related air pollutions. It's not necessarily just NO2, but it's a marker for all vehicle emissions. And this meta-analysis found that for every 20 microgram per cubic meter increase, there was around a 28 gram decrease in term birth weight. So 28 grams seems fairly small. This is around 1/4 of what the effect is for smoking during pregnancy. So even though it's small, it is substantial and it affects a large percentage of the population that's exposed to TRAP. There is heterogeneity in the existing studies, and we're hoping to address some of that in our study. So there's very different methods to estimate traffic-related air pollution exposure, and especially how you adjust for confounding, because we know different types of populations tend to live near roadways and in higher exposed areas. Adverse birth outcomes is also important because it's related to increased lifetime risk for chronic disease. So everything from heart disease to developmental disabilities. So one part of this project that I'm not going to talk about today is looking at emission regulations. And these have been very effective at decreasing tailpipe emissions over time. So the graph here, the dotted red line shows decreases in NO2 concentrations from 1995 to 2010. So you see this dramatic reduction in emissions, while at the same time, the amount of vehicles on the road has gone up. So the blue line shows the increase in traffic counts over time. Here we're looking at a study that Mary Willis did, where we examined all mothers living within 300 meters of a highway and the impact that had on term birth weight. And so if we see this reduction in NO2 over time, and there's a causal relationship between traffic-related air pollution and term birth weight, we would expect that association to decrease over time, which is also what we see here. So in the unadjusted model, if you lived near a road in 1996 to 1997, there was an approximate 40-gram decrease, which slowly reduced all the way up to the 2008-2009 association of around 28 grams. And so when we did a lot of adjustments and matching on different variables, we see that these are reduced quite a bit, but we still see this general decrease in the impact of living near a highway over time, which parallels what we would expect from tailpipe emission changes. So this talk is going to be focused specifically on congestion. So we know that congestion leads to very high levels of localized air pollution. So if you look at some of the measurement studies, a lot of the air pollution from vehicles dissipates to approximate background levels at around 300 meters. So this is very localized air pollution hotspots. For some type of pollutant, such as ultrafine particles, that might go out even to a kilometer. There's diverse ways to reduce congestion and local air pollution. And so this can include major infrastructure projects such as electronic tolling, managed lanes, road capacity expansion, increased public transit. So there's a lot of interest and a lot of money put towards congestion reduction, with benefits to health being a major driver. And so that's not the only driver, but that's a major driver to some of these projects. These programs also offer natural experiments where we can see changes in traffic-related air pollution and potentially health outcomes. So leveraging these quasi-experimental designs, we can have better confidence in the actual impact of these changes on health. And that's what we're trying to do in this study. So the conceptual framework for what I'm presenting here, the general question is, among pregnant women residing near highly congested roadways, how did programs, especially construction improvements, impact adverse birth outcomes for those mothers? So we start off with identifying high congestion areas, identify programs to reduce congestion on those roadways. Can we measure the change in congestion that happened and how that would impact traffic-related air pollution exposure, and then impact or be associated with reduced adverse birth outcomes? So this is trying to capture the whole chain of accountability, from the policy impact to changes in air pollution to changes in health. So the study population here for this specific aim, we're looking at all births in Texas from 2010 to the end of 2016. So this is around 3.7 million births. We're using the Texas Vital Statistics data, where they have very detailed information, first of all, on residential address that we can use to assign exposure, but also on infant and mother sociodemographic characteristics and birth risk factors. So these are the confounding factors that we're worried about, especially when we're looking at traffic air pollution. And then we're also going to use standardized methods to assess this chain of accountability. So everything from construction projects to changes in congestion. So to identify high congestion roadways, we're using the Texas 100 data set. And so David Schrank leads this project, and he's a partner on our study. So this is a data set that leverages what's called vehicle telematics. So this is basically connected vehicles and devices that are measuring vehicle speed. And so the key inputs to measure congestion that are used in the Texas 100 are actual travel speed and free flow travel speed as the reference. These are all at 15-minute intervals. And these are then combined with text.vehicle volume and vehicle occupancy when you're looking at total person hours of travel delay. So this is just an example here that's showing using this type of data. You can see the changes in traffic speed as well as estimates of delay, and this is person hours per year. This is available in Texas for 1,800 road segments. These are primarily the most congested roads in Texas from 2010 to 2020. And there have been changes over time in the methods to look at congestion, which is primarily due just to the enhancements in data quality that are coming from these type of telematics data sets. And so these are INRIX data that we're using to estimate congestion. This is really exciting because a lot of the existing research just looks at traffic volume, right? So where you have AADT estimates, those are used as inputs to exposure models rather than actual congestion. So our key measures that we're going to be looking at is total delay. And so this combines the intensity of congestion on a road with the magnitude of vehicles. So it's going to capture the difference between a 10-lane highway and a 4-lane highway with the same amount of congestion, but just different volume. The next measure is excess CO2. And so what's nice with this measure is that it uses the EPA MOVES model to predict excess CO2 from congestion plus the CO2 from free-flowing driving conditions. So we're using this as a surrogate for excess air pollution. We may also run the MOVES model for NO2 as well as CO2, but we're going to see how much work that's going to be for the added benefit. Okay, so we can measure congestion. We can locate roadways that have high congestion. And the next component of that chain of accountability was looking at where large infrastructure projects are happening. And so this is an example of current projects in Texas. This is an amazing interface where you can click on a road. It tells you information on construction that's underway, that's beginning, that's planned. But we really need historical road construction. So we're going back to 2010. And so here we're using a similar data set that's in the project tracker, but this is looking at historical projects and construction billing. So for this time period, this data set has around 26,000 projects where we know the control section that that project happened, so the location of road, the date the work began and was completed, the project type, and the project cost. And so this is a nice standardized database to start looking at major construction change, but we're also looking for other databases. And so if anybody is listening and has ideas, please reach out to me after or in the chat. There's the electronic project record system in Texas that we still haven't explored, as well as specific environmental impact assessments for really large construction projects. And so if these are going to impact air pollution, they probably have local air pollution projections and models already done as part of the impact assessment planning process. So this is just looking here, this first graph, it's hard to see. On the y-axis, this is 2011 ranking of congestion versus 2019 or 2020 rank of congestion. And so this is all delay. You see this one-to-one line where we have projects that are becoming less congested, and we have streets that are becoming less congested and streets that are becoming more congested. So just looking at rank per year standardizes for some of the methods and data set differences that have happened over this 10-year period. What we're going to try to do is apply this to specific road segments where we know projects occurred. So this graph shows the green lines where projects started and stopped and how annual delay changed over that time. We're still trying to figure out these methods to account for some of the differences that occurred in the data quality. So the goal of integrating all this data is to use what's called a difference in differences analysis approach, where we can look at roads that had construction, a similar comparison road that didn't have construction, and look at the differences before and after in terms of how birth outcomes change for mothers who live near those roadways that had a project and that didn't. And so this is falling in line with the causal inference analysis approaches that are becoming more popular in the air pollution literature to look at how we can isolate a more robust association between air pollution, and especially air pollution change with some of these projects and health outcomes. So here I'm just going to talk a little bit about just looking directly at congestion. So if we look at these congestion associations and adverse birth outcomes, what do we see? So this is not the difference in differences causal inference approach. So here we take the full residential address of mothers, we assign the congestion on the nearest roadway, and then we take the density of the congestion measures within different buffer distances, where we weight the road length by the different congestion measures. And so this is just a map of what a 500-meter density of total congestion looks like for Houston. If we look at the cohort demographics, here I have distance to a congested road. So the lowest exposure if you live 1 to 1.5 kilometers from that road versus if you live within 250 meters of that road. And then the congestion metrics, the lowest 10% versus the highest 10%. And we see some of these standard patterns that tend to occur where we have higher minority populations living near roads, slightly less educated. But we see that change, especially with some of the congestion measures. So here, you're much more likely to have a bachelor, master's, or doctorate degree if you're in the highest 10% of congestion. And this is really the urban core phenomenon where we see very, very high housing prices and neighborhood sociodemographic characteristics along certain types of roadways near downtown cores. And this really gets at an equity issue where does air pollution matter as much if you live in a $2 million home with air conditioning and sealed windows versus if you live in a lower income home or an apartment building near one of these roadways. So we're spending a lot of time in this project trying to link in property information to our health analysis, as well as some of the neighborhood characteristics and gentrification data sets that are out there. So I know I'm running out of time, so I'm going to go through some of these results really quickly here. This is looking at the interaction between distance to a road and congestion measures for term birth weight, adjusted for a lot of individual characteristics down here, where we see that if you live within 250 meters, there's around a 5-gram decrease for all traffic, 7-gram decrease for trucks. We don't see a dose response related to how close you actually live to a road. If you look at preterm birth, again, we see slightly larger associations for trucks compared to all traffic. So around a 7% increase in the odds of preterm birth if you live near one of the more congested roadways within 250 meters. And we're using this interaction model to try to account for some of those differences in the patterns of sociodemographic characteristics of people living near roads. And so this is something that I think we have to be really careful with these type of analyses, because who lives near major roads can change based on different cities, neighborhoods, and contextual characteristics. So in conclusion, Texas really offers an ideal environment to study congestion. On the bad side, there is a lot of congestion. On the good side, there's a lot happening to reduce it. And Texas really has amazing data. I've been blown away by the data that's available. And future analyses will use more causal inference methods to try to look at these changes. So we're still early in this project. This is 1 year in. We have 2 more to go. So please reach out with ideas, comments, or data sets if you know of things that could be useful for this project.
Perry, thank you for your, I'm sorry. Perry, thank you for your very informative presentation. And Jill, we're ready to receive your presentation.
Hi, everyone. Can you hear me okay?
Yes, we can hear you.
Okay. Thank you, everyone. I'm Jill Law, an assistant research scientist from UC Riverside. Today, my topic is reducing community exposure to diesel. excuse me, for, okay. Today my topic is reducing community exposure to diesel emissions through health-conscious truck routing. So first, I would like to thank the health researchers for their thorough studies, which provide foundation for application researchers like us. And I would like to thank my team members for making this study happen. Okay, so we're here because we know the heavy-duty diesel trucks and their environmental and health impacts. Unfortunately, in Southern California, a large percentage of population and schools are actually located near major freeways and corridors. Those communities have some serious health concerns over the diesel-related air pollution. Okay, just to give some background context, we will look at the Carson City in Southern California in this study, which is right next to the Port of Long Beach. So the Port of Long Beach is the second busiest container port in the US. Just look at the volume here. Based on the port website in April 2021, so in the last month, the Port of Long Beach imported more than 367,000 containers in 1 month, which averages to 500 containers each hour. So you can just imagine how many container trucks and trains need to pass this area each day. As a result, CSIRT has been working on several projects that investigated the emission mitigation methods in this area. Because Carson is such a heavy volume hub for heavy-duty trucks, so there are designated truck routes by the city, and the city advised the truck drivers to consider the truck routes at the first place. If pickups or delivery locations are not on truck routes, the city suggests the truck has to use the most direct route from a truck route street. So our question is there a route for a truck to take that would result in lower human and community exposure to emissions from the truck? To answer this question, we need to model how much of the emission from the truck will actually reach the sensitive population around the road and how much would be actually inhaled by them. So this is the modeling framework we use. We started from the source, which is the out of tailpipe emission, and chained the dispersion and exposure models to the inhalation of the emission. To give an analogy, imagine if a person is smoking a cigarette and walking by right next to you, you will likely inhale a certain amount of the smoke from the puff. Here, similar concept, we're trying to model when a heavy-duty diesel truck drives by the road, how much of the emissions will be inhaled by the near-road population. To estimate how much emission comes out from tailpipe, we applied the California 2017 MFAC model to model the model year 2012 diesel trucks out of tailpipe emission, using a commercial source of traffic speed in year 2015. So just a note, the average PM emission rate is about 0.02 gram per mile at 40 to 45 mph speed range. To note that this value is only like 10 to 5% of a model year 2007 truck, thanks to the advanced emission control technologies and the regulations. And for dispersion model, we use the R-line model, which is a simplified version of AirMod to use to access the near road concentration. We have many of the details in the report if you are interested. And for the human exposure assessment, we assume that the inhaled mass of the overall population is proportional to the location concentration and the population. The exposure duration and breathing rate here are applied as a constant in the study. So with all the calculation above, we can assign an inhalation value to the roadway network. Then we can combine the inhalation and travel time into a new cost and calculate the potential routes between a start point and destination. At the same time, we can also calculate the conventional fastest route based on the truck route network in Carson City that were mentioned before. So here is a snapshot of how the exposure costs look like for a given hour of day in May 2016, based on the meteorology data we obtained. The blue dots here in this map represent the sensitive places such as schools, public parks, and several senior homes. And the gray blocks in the back show the census blocks. The population at those locations are projected based on multiple assumptions and sources. So the bigger the circle, the larger the population. The darker the blocks, the larger the population. So the red line means that if the truck drives by this road, it has a higher value of inhalation cost due to their nearby population and the weather condition at that time. To simulate the truck trips, we extract 22 entry and exit points around the city, marked by the red circles, and the 25 truck destinations, such as the large retail stores and warehouse centers, which resulted in 1,100 trips. For each trip, as mentioned before, we calculate the baseline route, which is the fastest route based on the city's truck route network. And then we calculate the low exposure route and compare the attributes. Okay, so maybe the low exposure route now still sounds abstract for you. Here is an example of it. We calculate the truck trips at 10 a.m. at the left and the 10 p.m. at right, so that we can see the difference of population shift and the weather change. We can see that those sensitive places such as schools and parks, where have many people, are mostly gone at 10 p.m. And at 10 p.m., the working population returned to their homes within the census blocks. Then the fastest route is in coral color, and they are the same between 10 a.m. and 10 p.m. However, the low exposure route are different due to the shift of population and the weather condition. The low exposure route is slower than the baseline route. However, the model PM 2.5 inhalation reduced about 70%, and the NOx inhalation reduced about 31% in the morning and about 44% at night. This type of trip with considerable reduction of inhalation but slight travel time increase is what we like to see. And we have a summary of the 1,100 model trips. We found that about 23% of them are the good ones that we would be further considered as realistic truck routes. We also use the same approach in another community in East Los Angeles, and we have more details in the report as well. So from this study, we found that with a slight increase of travel time, exposure-based truck routing strategy can help reduce the community exposure to trucker emissions for about 20% of the truck trips. In all the modeled truck trips, about 13 to 23% of all of them are attractive low exposure routes. And we also found that street geometry plays a key role. For example, for these two little figures, the red lines represent freeways and the blue lines shows the signalized streets, arterials. So there are both advantage and disadvantage for these two street setup. For this one, it can be fast to get to the green dot from the freeway, but the green dot could be too close to the freeways and its emissions. For this setup, the green dots can be placed further away from the freeways, so it could fall out of the distant decay of the emissions from the freeway, but it could cause more travel time. And of course, there are many uncertainties such as the travel time and emission itself, and some limitations. But we hope this method can help us inform the truck drivers about nearby community, and it could lead to a future reduction program that can be combined with some other technologies, such as freight signal priority and eco approach and departure, to further reduce the out of tailpipe emission and the actual amount of exposure inhaled by the community.
So, Jill, thank you. And thank all of the presenters. Please let me allow you to make your acknowledgement, please. Please go ahead. I apologize.
Yes, thank you. I would like to thank my team members and the staff to make the symposium happen. If you have any questions, please feel free to email me or which is my supervisor. Thank you.
Thank you, Jill. We have a number of questions, and let's see if we can get through them with the allotted time we have left. Juan, there's a question, I'm gonna combine two questions for you that has come in. The first, it is, did you consider looking into the long-term exposures and exacerbations, and why or why not, and or the reoccurrence and frequency of short-term peaks?
Yes, and as I mentioned during the presentation, a separate study that was also part of the larger epidemiological research was looking into the long-term data and the relationships with the transportation variables. Sadly, we couldn't consider the respiratory outcomes since we only had 1 year of data. However, for the cardiovascular assessments, we did have about 5,000 participants and 5 years of data. So definitely some of these associations were still preserved in the long term.
Okay, thank you. A follow-up question as well. Were the lifestyle habits like smoking, diet, etc., of participants collected in the interviews, and are there any actual experimental data in the literature establishing the causality of PM obesity relationship?
Can you repeat the question, John? It broke up for a bit.
Sure. Were there lifestyle habits like smoking, diet of participants collected in the interviews, and are there any actual experimental data in the literature establishing the causality of PM and obesity, of the PM and obesity relationship?
So we did collect the smoking status, which was also a confounder for the models we later did. It didn't affect the outcome for the respiratory associations. Diet, it's a component very difficult to capture objectively because of self-reported data. Wiggum and Associates have been looking at fruit and vegetable intake using an objective marker. So we are aiming to publish some of that information later on. However, as part of this data collection, we focus more on the clinical outcomes. As far as causality and approaches, they're very difficult to assess, given that you cannot willingly expose people to air pollutants and follow them longitudinally to see any associations. However, some of the work we're doing now at Stanford University is considered cohorts of people exposed to wildfire smoke. So definitely we are planning to pursue those associations further down the line. So thank you for the question.
Okay, thank you. And Perry, a couple of questions for you. Please talk about the benefit and strengths of quasi-experimental designs, and which exposure window did you look at?
Sure. So for the first one, I mean, there definitely is this big transition, I think, that's happening in environmental epi towards more causal inference methods. And so these are basically, it's still observational research, but they're just different methods to try to isolate a more robust association. So this is still it's not gonna replace a randomized control trial. It still is an observational study. But some of these methods might include like the difference in differences analysis, instrumental variables, propensity score matching. And so, especially with traffic-related air pollution, that's something we're really worried about, just who chooses to live near major roads or who doesn't have the choice to live far away from a major road, are things we have to take into account. So that's why we're really focused on looking at these projects, because those will have shorter term change potentially on air pollution, while the populations that are exposed may not change during that time period. I didn't talk about it here, but we're also trying to use wind direction as an instrumental variable. So people usually don't choose to live upwind or downwind of a major road, but that will impact their air pollution exposure. So trying to leverage those type of variables to get more robust associations between traffic air pollution and health outcomes. For what I presented here, the congestion data that we have is annual. So we didn't look at any trimester specific exposures. We can do that with some of the ambient models. So we have monthly predictions of PM 2.5, ozone, and NO2, where we can try to look at trimester specific exposure windows.
Okay, thank you. And Jill, we have a question for you as well. And it is this: if the low exposure route is longer, it leads to more total emissions. Does your work try to optimize this as well?
Okay, thank you for the question. So usually the low exposure route is shorter in the distance, but it takes longer time. So the overall speed on the low exposure route is usually slower than that of the freeway route. So in the optimal case, the low fuel route is also the same with the low exposure route. So it's the same case in the example trip here I just showed a moment ago. So we hope we can dig more into those potential routes and link them with the city so that the truck drivers can actually consider using them. Thank you.
Very good, thank you. And let me pose a question to each of you. To the extent you have focused on your next research efforts, could you share whatever plans you have with the group as to the next research you intend to undertake that will build upon what you've shared? Jill, why don't we start with you?
Okay, great. So one of the future direction that I mentioned is to couple this low exposure route with many other emission reduction strategies. For example, less idling and a more smooth passing at the intersections, and AI-assisted driving. And another direction we're looking for, and is also founded by CARTIS, is that we try to develop a metric to characterize the population averaged inhalation, pollutant inhalation from the traffic-related air pollutants, so that we can actually compare it within different communities, and we can actually quantify which variable can contribute to more inhalation. For example, if we're having the same emission from the on-road heavy-duty trucks, but we have different weather conditions, and we have different geometry of the streets, we have different distribution of populations, how will the inhalation value vary and change based on those different factors? Thank you.
Thank you. Juan, please.
We need more monitoring and more research. So the current works I'm involved with the University of Paso includes a bi-national effort of air monitoring within El Paso, Texas, and Ciudad Juarez. Dr. Wenwai Lee is leading that one. And here at the Sean Parker Center at Stanford, we're focused more on the effects of air pollution due to wildfire smoke. And we're going beyond the cardiovascular effects also to consider markers of immune health. To see if, for example, air pollution exposure, it's affecting DNA methylation of specific genes. and elucidate what are the systemic effects of these pollutants in exposed population, vulnerable populations, and even pregnant women.
As I mentioned, we're just getting started on this project, and I think the more I try to put into a presentation, the more it shows I'm excited about the research. So I think this is a good example of where we have a lot of really amazing data that we're bringing together. So this is really like a data science project where we're trying to add some new methods to air pollution epidemiology. And so I think that will lead to hopefully some more robust understanding of how do you reduce congestion, traffic air pollution, and then health impacts. And equity is going to be a big part of that. So not only who's exposed the most, but who experiences the most impact to health. And so that could be from cumulative impacts of traffic air pollution with other lifestyle risk factors. And so that's something that we're going to be paying a lot of attention to as we move forward with this project, trying to pull that those other data sets together.
Very good. Thank you very much. We have a few minutes left. So panelists, if you'd like, we can afford you an opportunity to make any closing remarks you would like to make. And we will go in the order in which you presented. So Juan, do you have any closing remarks you would like to share?
Yes, I would like to share that it's great to see such amazing work being done all over the world and more attention put on these types of effects. I mean, air pollution is a major contributor. I think the current pandemic brought additional awareness to the effects of aerosols and how we're exposed to what we could call invisible components. I think it's great to see such amazing work, and I look forward to more of this group in particular to continue to be involved with the CAR team. And for everybody, thank you for your participation, and please more events like this, and hopefully we will come back in person for the third one.
And Perry?
Yes, I'll second the call for hopefully we'll be in person next year. I'm stopping making any predictions. I would just like to sort of repeat my call for anyone who is interested or has ideas for the research we have going on. Please feel free to reach out to me. We have a lot of different things, and the more collaborators, the better. So please reach out. And thank you for listening.
And Jill.
Hi. So for me, I actually have a question for Juan and Perry, who are the health experts. So as you can see, my exposure assessment is quite simplified. So it's just proportional to the concentration and the breathing rate and the exposure duration. I know that actually the particles you inhaled in your lung, some of them were out again, and only a part of them are deposited into the lung. Do you think I should actually use that dose as this indicator? And how do you usually assess the dose of the deposition amount of the particles onto the lung?
I can chip in. I work with a professor that was looking also at trucks, specifically diesel trucks, because the pollutants that are coming from these trucks mostly produce ultrafine particles that can bypass respiratory system and get deposited in the cardiovascular system. These are a little bit more expensive to measure because they're less than 0.1 micrometer. So definitely there's room for more monitoring on that regard. So you could kind of differentiate the type of emissions to consider. As far as the effects, I think Tony mentioned that there's granular data for health outcomes. Although it's important to be careful because some of that data is self-reported, not measured. So my recommendation is to proceed with caution, but do consider not only respiratory factors but also metabolic factors.
Okay, thank you. Thank you very much.
Yeah, one thing to add that I think is relevant to this as well as all EPI is that we tend to just rely on where people live. because we don't have information on detailed time activity patterns of how people move around and where they're exposed. And that data is much harder to get. But as we get more refined with predicting air pollution concentrations in space and time, we're also going to have to integrate human mobility in space and time to get more personal measures of exposure.
Yes.
Panelists, thank you. Thank you for your very insightful presentation. Audience, thank you for joining us. And of course, we are all grateful that Carteeth has provided this opportunity. And panelists, let me close by thanking you for the great work you're doing. It is very important as we move forward to forge solutions to the transportation, the emissions problems that we face, so that we can assure public health for every citizen in this country, regardless to where they may live. Again, thank you all for joining us, and this concludes our panel.
Thanks, John. Thanks, everyone.
Thank you so much, John. Thank you all.